So we can start whenever you're ready.
Okay, we are ready. So, buenos días a todos. La primera parte en español. Es un honor para nosotros en la Cátedra de Oftalmología del Hospital de Clínicas de la Universidad de Buenos Aires tenerlo una vez más a Rajesh Fogla. Rajesh Fogla es el corneólogo del mundo, uno de los mejores cirujanos del mundo. Ha diseñado un sinnúmero de dispositivos para facilitarnos diferentes técnicas quirúrgicas, no solo en la cirugía de córnea, sino también en la cirugía de segmento anterior. La realidad es que nosotros estamos tan agradecidos con su actitud para enseñarnos, para compartir conocimientos, complicaciones, y siempre está atento con nuestra cátedra, que lo hemos nombrado. He has been duly elected a visiting professor at Maimonides University, and we started the issue here at Buenos Aires University. So congratulations. As you know, he's a specialist in cornea and external disease, cataract and refractive surgery, areas of interest, lamellar corneal surgery, refractive surgery, ocular surface reconstruction. He's involved in teaching and training courses, in fellowship programs, in training courses in corneal over past 2 decades. Usually, he's in courses at American Academy, at ASCRS and ESCRS, huge numbers of publications. He published a lot in cornea and ophthalmology, in American Journal of Ophthalmology. He has obtained a lot of achievement award at American Academy and APAO meetings, gold medal from Intraocular Implant and Refractive Society. He's fellow from Scotland Ophthalmology Society, from England Society. Well, and again, it's an honor to be here with Dr. Professor Rajesh Fogla, and this morning he's going to talk about Big Bubble. Thank you so much. You can start whenever you want. Thanks. I don't know if you are mute.
I'm just, I'm not mute. I'm just trying to see. Yeah, that should be okay. Now, you're able to see my screen?
Yeah, perfect. Thanks
okay. So good morning, everybody. It's a pleasure to be with all of you today. And I thank Pablo for the invitation. And the topic he has given me is something that is very dear to me. It's about big bubble deep anterior lamellar keratoplasty, which I've been performing for the last 2 decades. And even as we perform every time, we are still trying to improvise to make it more predictable and successful without encountering any complication. So over the next 1 hour, I'll try and share all the tips I can to make sure that the learning curve for you is very smooth. I have no financial interest to disclose. Deep anterior lamellar keratoplasty refers to a surgical technique where you remove 90% of the corneal stroma, leaving behind the intact Dehiscence membrane and the healthy endothelium. So the biggest advantage is that you don't get any endothelial rejection. So you need to use steroids for a shorter duration of time. And since the surgery is performed in a closed chamber, it reduces the risk of intraoperative complications, unlike a penetrating keratoplasty where the surgery is done with an open globe. The risk of rejection is low, so you can use larger diameter graft, thereby achieve a better refractive outcome, reducing the astigmatism. And also getting a tissue from the eye bank is easier because you're not dependent on good cell counts for the anterior lamellar keratoplasty. The indications, the most common indications in my clinical practice are ectatic disorders, advanced keratoconus, keratoglobus, pellucid marginal degeneration, post-refractive ectasia, post-intracorneal rings or cross-linking, corneal scars. Sometimes we do see stromal dystrophies and degenerations. We have combined it successfully with ocular surface reconstruction. And at times when you have infections which cannot be managed through medical treatment, you can consider deep anterior lamellar keratoplasty. This report from the American Academy of Ophthalmology, published back in 2011, concluded that DALK is equivalent to penetrating keratoplasty in terms of the outcome, in terms of the visual outcome, if the surgical technique leaves behind a thin residual stromal bed, which is very uniform. It is superior to penetrating keratoplasty for preserving the endothelial cell density and thereby long-term survival of the graft. It has safety advantages because it's a closed chamber surgery. So it's a good option to consider when the endothelium is not compromised. So coming to the big bubble technique, this was developed by Dr. Mohammad Anwar and Klaus Teichmann. And this, in 2002, they described it in the 2 publications. In this technique, you make a trephination, which is almost 85 to 90% depth, followed by injection of air using a 27 gauge needle in the deep stroma, which results in a plane of separation, creating what is called as the big bubble. So my meeting with Dr. Mohammad Anwar back in 2003, 2004, and watching him operate definitely made a huge difference on the success rate of achieving the big bubble. Now, when we talk about DALK, these 2 terms of D-DALK and PD-DALK were coined by Dr. Sarnicola. D-DALK standing for decimetric DALK and PD-DALK is for pre-decimetric DALK, because the original plane of separation was thought to be the Dehiscence membrane when you inject air and create the big bubble. Now, so when you are able to expose the pre-Dehiscence layer, we call it D-DALK. This can be done using air, viscoelastic, or fluid. And the other option is you do a manual dissection to the near Dehiscence level, which nowadays, if you have access to intraoperative OCT, you can use that to guide the dissection to reach a very deep plane. A new surgical anatomy has been coined again by Dr. Sarnicola, which is published last year in Cornea. And this was based on the results of Professor Dua describing the pre-Dehiscence layer. So they tried to coin new terms called subtotal anterior lamellar keratoplasty and total anterior lamellar keratoplasty. However, at this point of time, these new terms are a little bit confusing, and it may take some time before we get used to them. The other major change is the work of Professor Harminder Dua. He published this paper back in 2013 and described the pre-Dehiscence layer, or the Dua's layer, which is again a surgical plane that you see when you inject air into the corneal stroma. The type 1 bubble typically starts in the center of the cornea, has a dense white outer border, and concentrically enlarges towards the limbus to a diameter of about 8.5 millimeter. Now here the plane of separation is between the stroma and the pre-Dehiscence layer. And in contrast, the type 2 bubble is something that forms between the Dehiscence membrane and the pre-Dehiscence layer. It has a very sharp outline, unlike the type 1, which has a dense white frothy margin. Here the outline is very sharp, and it can go across the entire cornea, and it typically starts in the periphery. And this is more prone to rupture compared to the type 1 bubble. The type 3 is a mix of type 1 and type 2, where it starts off as a type 1 bubble and then breaks through, becoming a type 2 bubble. In the preoperative evaluation, it's important that when you examine the patient on slit lamp, you look at the extent of corneal pathology, the corneal thickness, the scar, whether the scar is superficial or it involves the Dehiscence membrane, there is any presence of any corneal vascularization or limbal stem cell deficiency. And it's also important to look at the lid margins. In terms of the diagnostic tests, yes, regional pachymetry is very important. You need to know the thickness across the cornea, which you can derive either from the anterior segment OCT, or you can also get it from the tomography devices. We also look at the cornea in cross-section using the anterior segment OCT. Here, it helps us look at the scar and see whether that's involving the pre-Dehiscence layer or the Dehiscence. In case it is involving the Dehiscence membrane or the pre-Dehiscence layer, air injection should be avoided because you can have an undesirable event with the air injection. You can do a specular microscopy if possible to look at the endothelial cell count, and slit lamp photograph is important to document the pathology that you're operating. So when we select cases for big bubble, what are the cases that we avoid? Well, among the stromal dystrophies, macular dystrophy is something that can give you an abnormal outcome of the air injection. So that is something you need to be more careful. I'll come to the more details about it in my subsequent slides. Very advanced keratoconus, where the keratometry readings are beyond 65 to 68 diopters, the cornea is already stretched quite a lot. So in that scenario as well, when you try to inject air, you can end up having a atypical bubble, like a type 2 bubble forming more commonly. And sometimes you can get a type 1 bubble that starts, and as you try to expand it, it often ruptures. So extreme thinning, where the apex is less than 220 microns, is also something where you would want to avoid air injection. Any kind of scars involving the decimates, especially post-hydrops, or if cross-linking has been done and it has a very deep scar near approaching the decimates, in these scenarios, maybe it's not a good idea to try and inject air to do the big bubble DALK. Now, just to show you some clinical, so this is a macular dystrophy where air has been injected. You can see that it initially started off as a type 1 bubble and then went on to become a type 2 bubble. So you did not get a big type 1 bubble. So in this scenario, we had to go and do a manual near decimates dissection. The second is very advanced. You can get something as a bubble forming with a very nice, sharp, clear margin. So that's a type 2 bubble. The third case is a case of hydrops, where we are injecting air, and you find that as soon as you inject air, the air goes into the anterior chamber after the stromal emphysema. So this is again an undesirable event, which can again make the subsequent surgery a little bit more difficult for you. So there are some nice publications on looking at the predictive factors for the type 1 bubble formation, and all of them give the same information as what I have just alluded to. So this is something that you can look at. In terms of instrumentation, you do need trephiners. Typically, we use section trephiners, the endothelial punch. The stromal fixation forceps and the pointed dissector are optional, which are useful to introduce the air injection cannula. You need the blunt tip stromal, you need the stromal dissectors, which are semi-sharp in case you need to do a manual near decimates dissection if you have a failed air injection. And you need the blunt tip corneal scissors to excise the residual stroma. In surgical planning, regional pachymetry is important because it allows you to decide on the size of the trephine that you are going to use, because the area where you trephine should be ideally more than 550 microns, because that kind of matches up with the thickness of your donor tissue. If your peripheral bed is less than that, then maybe you cannot put a full thickness donor tissue on the bed. Maybe you have to customize your the donor tissue by using a microkeratome or manual dissection and prepare a graft which is about 400-450 microns, matching with the thickness of the host. And the information about the pachymetry also helps you plan the depth of trephination when you want to reach about 80 to 85% depth. In terms of trephine, most of us are used to the handheld manual trephines. So you have, in a similar design, the guarded depth trephines. These are available from Coronet or Network Medicals. Here the blade is only about 300, 350 or 400 microns. So you can use that to do a partial thickness trephination. The advantage is you don't have to remember the number of turns that you make with a suction trephine, and the risk of going through and through is also less with this. The other one is the Hesburgh-Barron trephine, which is available from a lot of manufacturers like Catena, Surgista, Jedmed, and even Moria. Moria has a special design where you can use the metal ring to preset the depth on the suction trephine to whatever desired depth, 300, 350, 400, so that you don't have to remember the number of turns. Once you apply the suction trephine, you can rotate the trephine and it will stop wherever the depth that you have already preset here. In the other ones, you have to be aware about the number of turns that you make. Each quarter turn of the trephine gives a cut depth of about 60 microns. So ideally, we make about 6 to 7 quarter turns, giving us a cut depth of about 360 to 420 microns. You can use the femtosecond laser to make very precise cut and shape cut in the form of a top hat, zigzag, or a mushroom. And in certain cases where you're doing very large diameter DALK, and you may not have suction trephines going up to these diameters, so then you can use a diamond knife and set it to the desired depth, make an impression on the cornea, and then you can use the diamond knife to make the groove along the mark that you have created. In terms of centration of the trephine, you can make a central mark on the cornea, but what I prefer to do is I use a caliper, set it to the diameter of the trephine, and then I make two marks, one horizontal, one vertical. So having these four identification mark 90 degrees from each other allows me the centration in a much better way. So just alone marking the center part, which may give parallax error, here you can see we are going 1, 2, 3, 4, 5, 6. So we went about 6 quarter turns, that's about 360 microns. But you can see that the trephination, the cut is touching all the 4 marks that I made. So it's kind of fairly central. If you just make one single mark, sometimes you can have parallax error and you can end up with the eccentric trephination. You also look at the depth of the trephination. With the suction trephine, you find that the cut depth is pretty uniform all around. The next step that I like to do is I like to debulk my cornea. So you do an anterior lamellar keratectomy at about removing about 40% of the stroma. This step allows deeper placement of the cannula because you have removed already 40% of the stroma. So your cannula is going to be placed at a deeper plane when you place it from the surface. So usually you reach about 80 to 85%. Because you have debulked the stroma, the risk of stromal emphysema is also minimized. And once you achieve the big bubble, you can quickly deflate the big bubble without having to do the anterior lamellar keratectomy, which can sometimes take more time, and also has the risk of deflating the bubble at the time when the anterior lamellar keratectomy is done. But if the apex is very thin, then you have to be careful. You need not do the anterior lamellar keratectomy because it can expose the predecimus layer. So here in that scenario, we just do like a peripheral debulking. So we try to leave the apex, the thin apex, we leave it behind. In terms of using a needle, yes, if you place your needle at the right plane, in a single attempt, you can achieve the big bubble. Sometimes you need multiple attempts to be able to create the big bubble. If you place your needle superficially, you end up with a lot of surgical emphysema. And this is quite typical in the learning curve because you are afraid of creating a perforation posteriorly. So you try to keep your needle a little bit superficially, you end up creating superficial emphysema. And then if you try to go deeper, and while you're exchanging hand or you're moving the syringe, the tip can move posteriorly. Like in this scenario, you can see that I put my needle inside. And as I'm trying to use my dominant hand to press the plunger, the tip moves down. And now when I inject air, the air is going into the anterior chamber because I have perforated posteriorly. So using the needle, the success rate of achieving a big bubble is somewhere in the range of about 65 to 69%. So what is the alternative to a needle? You can use blunt-tipped cannulas, which are bottom port, usually about 27 gauge, and they definitely increase the safety and the success rate of achieving the big bubble. I use the stromal fixation forceps to stabilize the stromal tissue while we are injecting the cannula, inserting the cannula. And because the cannula is blunt tip, you need a pointed dissector to be able to create the track. So now you can see that I have debulked my the anterior cornea, and then I go with the stromal fixation forceps. I hold the stroma and then I retract it. I go with my pointed dissector right to the base of trephination and then do a scratch mark to create a small break in the stroma, just about 1 millimeter. Then put in my cannula, which is attached to a 5 cc syringe with about 3 cc of air. And it's not necessary to go exactly to the center. You can go paracentral as well. And you inject air, and you can find that you can initiate the big bubble in a very reproducible manner. The other way of finding the depth is something that's a nice technique described by Ramon Canem from Brazil. Here, you measure the pachymetry thickness and then use a diamond knife, set it to about 90% of the depth. And just ahead of the trephination mark, you create a stromal cut. And then you do your trephination. This need not be 85 to 90% depth. You can even do a 50% thickness trephination. Then go to the original cut made by the diamond knife, which is at 90% depth. And you can use a pointed dissector to make the track. And then you can introduce your cannula through this track and you inject air, and you find that you can achieve the big bubble in a more consistent manner. But you do need a diamond knife, and you have to be careful that the amount of pressure that you apply with the diamond knife, if you are tempted and you want to go like more deeper, like 95% depth, and you press more with the diamond knife, sometimes you can go through and through because it's really very sharp. So how do you reach the ideal plane for air injection? When you are using the cannula, you can get a manual feel. You will feel a sudden ease of resistance to advancement of the cannula in the deep stroma. While you're trying to introduce the cannula in the deep stroma, if you feel a constant resistance and you find it's difficult to introduce the stroma, which means that you are superficial, so you can always go back, make a slightly a deeper plane, and then you can insert the cannula into that deeper plane. Some people like to put an air bubble in the anterior chamber, and they look at the reflection of the tip of the cannula against the air bubble. So you see a dark shadow between the reflection and the tip of your cannula. And you keep moving it till the reflection and the tip kind of come very close to each other. And that kind of tells you that you are at a deeper plane. It's also been described that you keep the pupil dilated, and against the retroillumination, you look at the tip of the cannula, and if you start seeing wrinkles in the Dehiscence membrane against the retroillumination, that again is a sign that tells you that your cannula is at a deeper plane. And the pachymetry guided I showed you in the previous video, if you have access to intraoperative OCT, you will not be able to visualize while your cannula is in place because of the back shadow that you get, but you can make the track, put in your cannula partially and withdraw it, and then you can use the IOCT to look at the track, which you can then identify. And if it appears superficial, you can always go back, initiate a track at a deeper plane. If it is at the right plane, you can put your cannula back into the same track, advance it forward, and then inject the air. There are newer femtosecond laser which have integrated anterior segment OCT. So using this femtosecond laser, you can actually make a track in the stroma which is coming close to the Dehiscence membrane. When you inject air, there is an initial resistance. When you see that initial stromal emphysema at the tip, then you feel a sudden giveaway sensation as the bubble initiates. And then when you try to enlarge the bubble, the resistance increases once again. And that's because if the eye is still a closed chamber and the aqueous in the anterior chamber does not have anywhere to go. So obviously the pressure is going to build up. So in this scenario, you will find that if you, like here, I'm trying to enlarge my bubble to the edge of the trephination. I'm feeling the resistance and I persist with my air injection. So the pressure within the bubble goes beyond its bursting point and you end up rupturing the bubble. So this is because when you inject air, you get a counter pressure from the aqueous in an intact anterior chamber. And as the bubble enlarges, the pressure both within the bubble and in the anterior chamber also builds up. And within the bubble, if it reaches beyond its bursting point, you have rupture of the bubble. So to overcome this, what you can do, so this was an experiment that was, this paper published in 2017, where they did experiments on human cornea mounted on artificial anterior chamber. And they varied the pressure within the anterior chamber, and they looked at the big bubble diameter. So one of the findings they found is when the pressures in the anterior chamber were raised up to 30 and 40 millimeters of mercury, the diameter of the big bubble that they achieved was only about 6.6 when the pressure was 30 and 3.4 when the pressure was 40. So showing that as the pressure builds up, it increases the resistance to bubble expansion. So using this, what we did was we do an initial injection of air to initiate the big bubble. And then we do a paracentesis to release aqueous so that the pressure within the anterior chamber is reduced. That means the counter pressure from the aqueous is reduced. And then you go back and inject air again. And you find that the resistance is much less than what it was prior to the paracentesis. So thereby you can avoid having a rupture of the bubble. The only corollary to this is sometimes even after releasing air, the aqueous from the anterior chamber, the bubble may expand to about 8.5, and you may still feel a resistance. So at that point of time, despite making the eye soft, if you still feel resistance and you're not able to enlarge, don't persist with it, because it may have reached its maximum limit and it can rupture at that point of time. How do you identify whether you have achieved the big bubble? Because sometimes there can be a lot of overlying emphysema and you're not very sure. The small bubble test is quite useful. So you make a paracentesis, release aqueous, and then put a small air bubble in the anterior chamber. If you have the big bubble, it will remain in the periphery. And as you deflate the bubble, it comes back to the center. The other way to look at it is you make a paracentesis, release aqueous, make the eye soft. Now, if you touch the eye using an instrument or the dry merocell sponge, you will find that the peripheral cornea beyond the bubble will be soft, whereas in the central part, when you touch it where the big bubble is, you will find that it's still firm because of the presence of big bubble. If there is no big bubble, this will usually be quite the same softness as what it is in the periphery. There is a recent paper from Massimo Busin where they have described the visualization of the big bubble using the intraoperative OCT. So this is, again, if you have the access to intraop OCT, you should be able to visualize this as well. So once you get the bubble, you need to deflate the bubble. Normally, what we do is we make a paracentesis and we soften the eye. We release the little bit of the wire, the lid speculum, to ensure that the posterior pressure is minimized. And then we deflate the bubble using a slit knife with the cutting edge facing forward. And this is done in a quick manner, always also referred to as the brace slash. And I also recommend that the point of entry where you're going to make the opening in the stroma, mark that with a marking pen so that you can identify where you have deflated the bubble. Otherwise, sometimes when there is a lot of emphysema and you make a very small opening, it may be difficult to go back and identify where the point is. Another safe technique is to put some cohesive viscoelastic on the corneal stroma and then pass your knife through it, as you see in this video. And as the bubble is deflated with the sharp knife, the air comes out through the viscoelastic. So the bubble collapses slowly. It doesn't collapse fast, so thereby improves the safety. The second video is showing you what we do by releasing aqueous and making the eye soft. You can see that the bubble is collapsing very soft, gradually. Once you have deflated the bubble, the next step is to excise the residual stroma. It's important to mark the point of deflation. And if you have not done a debulking, you can do the debulking first and then go ahead and excise the residual stroma. One option is to inject some cohesive viscoelastic through that small opening that you have made in the stroma to push the posterior layer backwards. So that gives you space to open up the residual stroma. Use a blunt tip scissors. This is a scissor that I designed, which is available from stores, where the lower blade is slightly longer than the upper blade. And you can enlarge the opening, divide it into 4 quadrants, and you can then excise each quadrant individually. You have to be careful when you're excising this stroma. There can be some peripheral additions, because especially if your bubble has not gone all the way to the trephination mark. So you can either do a peripheral separation with using a blunt instrument, or you can excise the bubble only in the area where the separation is, and the peripheral residual stroma can be trimmed down, which I'll show later. If you have a lot of peripheral stromal emphysema as well, it's important to use a marking pen and mark the edge of your trephination, because if you don't mark it and you have a lot of peripheral stromal emphysema, while you're excising the residual stroma, you may actually excise the trephination edge as well if you're not very careful. The donor size for ectatic disorders is usually the same size, but if I'm doing it for other indications like scars or dystrophies, I usually oversize by 0.5 millimeter. If you're using a femtosecond laser to do the host and the donor, it can be just 0.1 millimeter disparity. I like to remove the donor Dehiscence membrane, but there are a lot of surgeons who have provided good results even without stripping the donor DM. So either way, it can be done. You can remove the donor DM either using a dry Vexel sponge, or you can use a fine tying forceps to peel off the Dehiscence membrane. And sometimes you can use trypan blue to kind of stain the Dehiscence membrane, or you can even put a drop after you have done the removal just to identify any residual Dehiscence bits that may have been left behind. In terms of suturing, use a 10-0 monofilament nylon. You can use interrupted, continuous, or a mix of interrupted and continuous. I like to take slightly wider bites, 0.75 millimeter bite on the donor side, 1 millimeter on the host. In terms of depth, it's about 80% depth on the donor and a 95% depth on the host side. That ensures that the apposition is quite optimal. Intraoperatively, at the end of surgery, you can use the Maloney's keratometer to try and look at the reflex and adjust your suture so that you leave behind a nice circular reflex. And post-operatively, suture manipulation, I like to do in the first 2 to 4 weeks in case there is, high astigmatism. If it's a running suture, I will adjust the running suture to minimize the astigmatism. Or if I find that the sutures are loose or tight in any particular axis, I will go back and I will replace those sutures, because these have implications in the long-term refractive outcome of the corneal graft that you have performed. The recovery is quite good because you have a healthy endothelium, so the graft clears up pretty well, and there is not much of inflammation as well. So within 2 weeks, you can find that the patients have good visual recovery and the eye also looks pretty quiet. The use of femtosecond laser gives you greater precision and flexibility of incisions. You are not limited by making the diameters of 0.25 step. You can virtually make any diameter in that you desire. You can even make oval grafts if you want, but I've never done an oval graft. Because you make these shaped incisions, the surface area is larger of the graft-host junction, and also it's like a jigsaw puzzle, so the donor and the host fit very well, and you can, it also allows you to place the cannula at a greater depth with much better accuracy. And although initial cases I had done early suture removal, but I definitely ended up with unpredictable astigmatism. Even though the graft-host junction wound is much more secure, I would recommend that we remove the sutures at a much later date. So in terms of doing the surgery, so here we just make a central mark for centration. That's using the Zimmer Z6. So we make the peripheral trephination on the host, then we make the donor trephination cut in the same mushroom configuration. I'm doing the anterior lamellar keratectomy. You can see the peripheral configuration of the femto laser cut. And once we have done the debulking, I am using my stromal fixation forceps to retract, and then with the pointed dissector, go to the base of the cut and just make a small stromal pocket, introduce the cannula, and then just small wiggling motion. You can see that there was a sudden giveaway sensation, the cannula sliding forward. That tells me that I'm in the right plane. Inject air, get your big bubble, do a paracentesis to soften the eye, reduce the counter pressure, and then you can, that's the small bubble test. I'm putting some viscoelastic on the corneal surface, then I'm using the slit knife to deflate the bubble, and the rest of the steps are the same. Here again, you can see the edge has become white. So it's important to mark this again with a marking pen. If you're not very, visibility is not too great, otherwise you'll end up excising this as well. And then when you're trying to oppose your donor, you may find that it doesn't sit very well. So that's the donor lenticule that we prepared, and this can be secured with sutures using interrupted sutures, and that's the Maloney's keratometer that we use at the end of surgery. Post-operatively, it looks great. While the sutures are in, they are unaided, and vision is also very good. This patient had about 20/40 vision with minimal astigmatism. But once you remove the sutures, even in these eyes, the astigmatism can be unpredictable. The other option instead of air is to use viscoelastic. My colleague Shigeru Shimura does all his surgeries using the visco bubble. Here you have to make a paracentesis, make the eye soft, put an air bubble in the anterior chamber. And then as I'm injecting the viscoelastic, this is cohesive viscoelastic, and this is a 25 gauge cannula. You inject air and you find that you can get a visco bubble. and the movement of the air bubble in the anterior chamber to the periphery also guides you as to how much of the viscoelastic you want to inject. And then again, you open up the residual stroma, and then you excise it to expose the pre-Dehiscence layer. You can see there. It's important to wash out all the viscoelastic at the end of removal of the anterior stroma, because if you don't remove the viscoelastic and have trapped viscoelastic in the interface, it will be more prone to developing a double anterior chamber. Sometimes after multiple air injection, if you fail to achieve the big bubble, then I like to use, I have to do a manual dissection. So I just make a groove in the periphery. And this is a stromal pocket forceps that I designed. Earlier, I used to use a blunt Westcott for this step. So you can use this instrument and make this peripheral groove along the trephination edge, both clockwise and anti-clockwise. So you can see that we go a few clock hours and we make this on both clockwise and anti-clockwise. And after this, it's more like the Malbrand's peeling technique. You can see my left hand is pulling the stroma. And if you're at the right depth of the plane, you will find that the posterior stroma, you'll be able to peel off the residual stroma quite easily without having to do a lot of dissection. So if you have patients like this where there is post-hydrop scar and the scar is involving the Dehiscence, so here we do the manual DALK. So here I've gone ahead, I mark the outline of the flesher's ring, and then I've done my trephination. I do the initial debulking, and then I come to the periphery, make my groove. And then, so this groove you can make in the initial start of surgery as well by using a diamond knife and making a vertical 90% depth cut, so that to come back and to make this plane of dissection, you can just start it from that original cut that you made using the diamond knife. And here you can see it's the left hand that's doing most of the work. The left hand is stretching the stromal tissue. As you stretch the stromal tissue, you get the separation of the fibers. The right hand, the stromal dissector, is basically helping me break those fibers that I have stretched. So I'm not trying to use the instrument in the right hand to create a separate plane. So thereby we can maintain a uniform plane of dissection in this scenario. So the instrument, the lamellar dissector and the pocket forceps, these are again available from stores. The same case, you can see the post-op anterior segment OCT, we had a nice uniform bed. In the initial post-op, the thickness was only about 30 to 35 microns. And at 1 month post-op, we can hardly make out the residual stromal bed. In terms of post-operative medications, I like to use prednisolone acetate 1%. For normal cases, I start off with QID for a week. Then over the next 2 to 3 weeks, I start tapering them. And then I move on to a softer steroid like fluorometholone and use it thrice a day for 6 to 12 months. Usually I use the topical soft steroids till the time the sutures are in place. However, if you're doing it for eyes with prior history of allergic eye disease or in children, there I would like to use the prednisolone acetate for a longer duration of time. In a lot of situations where I don't want to use topical steroids for a longer duration, in India, we do have tacrolimus 0.03% ointment available for ophthalmic use. So I like to use that once a day at night along with the topical soft steroids. The antibiotic drops are continued till the bandage contact lens is on the eye, usually for a week or 2. The lubricants have to be continued for long duration of time. Sometimes we also give them the lubricant gel for bedtime use, depending on the indication. Suture removal or replacement to manage astigmatism, I usually start from 3 months. And this is something which is very important because there's no point in doing a good surgery and a clear graft and ending up with a very high astigmatism, because that does not give you a good refractive outcome at all. So I think selectively you can remove sutures, but if you have to remove sutures in the early postoperative period, I would recommend that you go back and replace the suture with optimal tension rather than leaving that area without sutures, especially if you're removing more than 3 or 4 sutures to manage the astigmatism. In terms of the outcomes, yes, there have been some papers looking at the cornea registry, and they have found that the outcomes, the visual outcomes of DALK has been inferior compared to penetrating keratoplasty. So when you look at the registry outcomes, which has a surgeon pool of experienced and inexperienced surgeons, you can have these kind of variable results. But in literature, this is a nice paper published from Moorfields, and they have included series with more than 100 cases. And if you look at the single surgeon series, where the experienced surgeon has done more than 100 to 200 cases, the patients having corrected distance vision of 20/40 or better usually is in the range of about 80% or better, and the perforation rate is also very less. But if you look at the current study, which is from Moorfields, and they had multi-surgeon, the perforation rate was quite high, about 45%. And because it had a lot of trainees as well, they converted 24% to penetrating keratoplasty. And in these eyes which converted to penetrating keratoplasty, these eyes also had rejection episodes. So basically, in the conclusion, they say that the results are similar to penetrating keratoplasty in a multi-surgeon setting. And they said conservative management for intra-op perforation is advisable because it's safer than conversion to penetrating keratoplasty, and you can avoid having rejection episodes. This is another paper from Spain where they looked at the setting of DALK versus penetrating keratoplasty in low risk and high risk category. In the low risk category, DALK and penetrating keratoplasty outcomes were quite similar, but in high risk situations like post-herpetic keratitis or corneal scars with vascularization or with surface problems, they found that the outcomes of DALK were superior. So there are advantages of DALK compared to penetrating keratoplasty. So this is our paper, which we published back in 2005, looking at surface reconstruction in combination with DALK for unilateral chemical injury. And in the 7 eyes that we did this, we had favorable visual outcome in all these eyes with long-term follow-up. So before we go into complications, Pablo, do we need to discuss something, or I can go ahead and discuss complications?
Okay, go ahead, thanks.
We'll go ahead, okay.
Yeah, please.
So in terms of complications, complications are an inherent part of DALK surgery. So I don't think that there is any experienced DALK surgeon who will say that I've stopped having complications. I still do get them. One of the most common complication is that you can have intraoperative perforation. You can have a single perforation or multiple perforations. The main part is how you manage them and recognition of the complication intraoperatively. If you have perforation, you have an increased chances of having post-operative double anterior chamber with detachment of the posterior layer. Now, if you have this can very easily be managed by injecting air or a non-expansile gas bubble using sulfur hexafluoride into the anterior chamber. It's important to avoid pupillary block by keeping the pupil dilated and monitoring the intraocular pressure. Or intraoperatively, if you have realized that there is a perforation and you're going to do a large airfill, you can go ahead and do a small inferior PI surgically to avoid the pupillary block and the Uret-Zavalier syndrome. Now, this is a case where we had a very large perforation because a 6-year-old child with history of corneal ulcer and with perforation. So when we were doing the DALK, we ended up with this large perforation, you can see, measuring about 3 millimeter into 1 millimeter. And post-operatively, despite the best of our effort of putting a gas bubble in the eye, we ended up with this separation that we had. So, and it's a young patient. So what we did was, instead of converting to a penetrating keratoplasty, we did full thickness sutures that we placed, one horizontal, one vertical, and again put a gas bubble in the anterior chamber. And you can see that at 2 weeks post gas bubble, the cornea has cleared up very well, just showing the faint scars of the suture tracks that we had put. And we were able to improve the vision to 20/30. And she still, after 8 years, maintains a clear graph with good vision. Now, this is another scenario where you can have a macro perforation. So you can see I'm doing a big bubble and I ended up with a burst bubble. Now, this was not a small perforation. You can see in the image, lower image, that this is a large perforation going from one edge to the other. And during this surgery, we had the intraop OCT, and you can see the red arrows indicating the large bubble that you have had. So in this scenario, normally you would have thought that you have to go and convert to a penetrating keratoplasty. So what we did was we did a manual dissection. We put in the donor graft in place, keeping an air bubble in the anterior chamber. End of surgery, we went with a reverse Sensky, and we gently nudged the ruptured edges of the posterior layer, and we tried to oppose the two edges. And then we had already done an inferior peripheral iodectomy in this case as well. and we left a large air bubble in the anterior chamber at the end of surgery. So in the lower image, you can see after putting the air bubble in the anterior chamber, the intra-op OCT shows that the posterior layer is well opposed. So this patient, you can see post-operatively, there is a nice clear graph. The rupture is partially going through the visual axis, and the anterior segment OCT at 1 month, it shows that the cornea is fairly uniform in thickness. There is a small separation in the posterior layer, and the patient had best corrected visual acuity of 20/40 at 3 months. And if you look at the pre and post topography, you can see compared to the pre-op topography, the post-surgery topography is fairly uniform. So this is a nice paper looking at the management of type 2 bubbles. Sometimes when you inject air, you get a type 2 bubble. So the common question that people ask is, do you open up the type 2 bubble? Do you remove the residual stroma in type 2 bubble? So they had 3 groups. In the type 1, they tried to bare the Dehiscence membrane. In the type 2, they did a manual dissection, and they just did a small nick to release air from the type 2 bubble. In the third group, they opened up the type 1 bubble and then released the air. So they found that the risk of conversion to a penetrating keratoplasty was the highest in the first technique, where they tried to bare the Dehiscence membrane, and the post-operative complication was also quite significant with double anterior chamber and Urez-Zavaleta syndrome. Whereas in the second and the third technique, in all eyes, the Dehiscence remained intact, and they did not encounter any conversion to penetrating keratoplasty. So just to show you, so this is a case where I'm injecting air, I get a type 1 bubble, and you can see now it becomes a type 2 bubble. You saw that type 1 and type 2. So what do you do in this scenario? You come back, you can see that's the outline of the type 2 bubble, and you have that's the outline of the type 1 bubble. You make sure that you don't puncture into the type 2 bubble. You release aqueous. You can see that as I release aqueous, my type 1 bubble, the type 2 bubble has expanded almost close to the paracentesis that you made. Then I went and deflated my type 1 bubble. I'm putting in a spatula inside the type 1 bubble, enlarging the size. And so there is somewhere there is a break between the type 1 and the type 2 here. So the air from the type 2 released, and it got deflated. We put an air bubble in the anterior chamber, and then carefully we excise the stroma from the area of the type 1 bubble. So you see that we have basically, so there is some residual stroma in this part. So this residual stroma, we manually trim it. How do we do that manually trim? I'll show in a subsequent video. We put in a graft in place, and then if required, you can put an air bubble in the anterior chamber. This is another old images from an earlier video where we used to think that the type 2 bubble is a split in the Dehiscence membrane between the banded and the non-banded portion. So the small bubbles are in the anterior chamber. The large bubble is the type 2 bubble. So using the knife, you make a small slit, and as the air releases from the type 2 bubble, the small bubbles in the anterior chamber move to the apex. This is again an old video where I'm trying to open up the type 2 bubble. So that's what I'm holding is the pre-Dehiscence layer. And now I'm just trying to see if I can, so I have a blunt scissors, and the moment I touch the Dehiscence, it ruptures, and it's not like a small rupture, it's a macro rupture. And sometimes to recover from this can be difficult. This is a macular dystrophy where I've injected air. I got a type 1 bubble, and the bubble is, I've kind of overinflated the bubble by injecting more air because I wanted to reach to the inferior part of my trephination, edge of my trephination. Now watch while I'm doing my paracentesis, the bubble ruptures at a point away from the paracentesis, which means that the compressed air within the bubble, type 1 bubble which was there, as soon as I reduce the counter pressure by making a paracentesis, the intra-bubble pressure expanded the type 1 bubble, which resulted in a rupture. And that's because the pre-Dehiscence layer in macular dystrophy is not as elastic because of infiltration from the deposits of macular dystrophy, making it more rigid. So you will see that this is again showing you a type 1 bubble, and you can see the deposits in the posterior layer. This is again a type 1 bubble in a macular dystrophy, and anterior segment OCT shows you that the posterior layer is 72 microns thick. And on slit lamp image, you can see those deposits in the posterior layer. You can get perforation when you're trying to excise the residual stroma. So you can see that especially in a soft eye, when you lift up, when you lift up your tissue to excise the peripheral stromal tissue and you're using a sharp pair of scissors, you can end up perforating. And also, if you are trying to take larger bites, you can end up perforating the posterior. So always take small bites, use a blunt tip scissors. And if there are any adhesions between the stroma and the posterior layer, try to separate them first, or use this horizontal trimming technique. That means your scissors are not vertical. Keep your scissors horizontal and try to lift up the stromal tissue and just trim the tissue. So even if you leave behind 70 to 80 microns of tissue in the periphery, it doesn't affect your visual outcome, but you have a nice uniform bed that allows a better apposition of the graft-host junction. Although you do not get endothelial rejection, epithelial, subepithelial, and stromal rejection can still occur after DALK. The epithelial, subepithelial rejections look like similar to what you see in adenoviral keratoconjunctivitis, but here the nummular spots are limited to the donor graft. There can be some amount of conjunctival congestion, and especially if you have broken sutures and you have vascularization, you can get rejection, stromal rejection as well. And the risk factors are basically the prior allergic eye disease as well. So in these eyes, you may need to continue the topical steroids for a longer period of time. The rejection episodes usually respond well to steroids, and I usually maintain them on topical tacrolimus if they have had an episode of stromal rejection. There have been papers described using cryopreserved cornea versus fresh cornea, and they've had similar visual outcome, but the rejection episodes have been much lower when you are using an acellular cryopreserved cornea. This is another paper that we published last year where we used decellularized gamma irradiated corneal lenticules. Now these donor corneas can be stored in room temperature for 2 years. It has a nice shelf life, and they can be used for any kind of anterior lamellar keratoplasty. We use for a keratoconus and corneal dystrophy, and we achieved clear graft and good visual recovery. Compared to fresh donor corneas, we found that the epithelial healing took a slightly longer period of time, and there was an initial haze in the donor graft, which cleared over several months. Other complications are common to what you see in penetrating keratoplasty: loose or broken sutures, epithelial defect, associated melt, interface vascularization, and lipid keratopathy. Sometimes you can get interface microbial keratitis from donor contamination. So it's important to review your patient in the first 2 weeks. And if you see any such event happening, it's important that you immediately replace the donor graft, because medical management usually does not give favorable outcome as the organism is trapped in the interface. Now, this is a case where the patient had undergone a DALK and the surgeon had put a full thickness graft, and obviously it did not oppose very well. And when the suture removal was performed, he ended up having one edge which was elevated. So we removed the anterior graft, we went back, made a bed, did a big bubble, excised the stroma, and the original donor, what the primary surgeon had put, we replaced it and we placed suture because that donor tissue was of normal thickness, and we were able to complete the surgery with good outcome. This is a patient who achieved 20/20 vision after a DALK surgery, and the indication was post-LASIK ectasia. She had high myopia, so she overwore her soft contact lenses as she was a radiologist, and despite all the instructions, she didn't listen. So she got blood vessels coming into the stroma, into the interface, ended up with lipid keratopathy affecting the visual axis. So we went back and we did a trephination, did the debulking first, and then the primary surgery was a manual near Dehiscence DALK. So we knew that we had some amount of stroma that we had left behind, and there were blood vessels, so we wanted to go into a deeper plane. So we were able to initiate a big bubble and complete the surgery. This is again a patient who had a successful big bubble DALK, and then he was lost to follow-up. He had broken sutures, never went to the ophthalmologist, and he developed a microbial keratitis, which was managed medically, ended up with a dense scar, and the scar was involving the visual axis. He came back to us. You can still see there is a broken suture at 6 o'clock. So here we took him up for surgery. So we did a repeat DALK. So we went ahead. We did the partial trephination about 350 microns. We were trying to deepen the groove, ended up with a perforation there. So then we went to the opposite quadrant and using a Sinskey hook, We retracted the stroma, and then we tried to break the posterior stroma, trying to identify the original plane of surgery, which we were able to identify. We tried to maintain the anterior chamber with air, but with the manipulation, the air kept leaking out. So we went ahead and placed a suture to prevent that air from leaking out and the eye becoming very soft. And then once we identified the plane, then you can go ahead and cut the graft junction using a pair of blunt tip scissors. And once we completed this, you can see that we made an inferior paracentesis, vertical paracentesis, did a surgical PI. And then you can see that's the infection scar. The infection was almost full thickness. And those are the radiating folds of the scar. Because we were worried about the posterior not opposing and having a double anterior chamber. So we wanted to leave a large air bubble in the anterior chamber. That's why the inferior PI. So that's what it looked like. So this is early post-operatively, and you can see this is at 3 months. He went on to achieve a 20/30 vision in this scenario. The graft junction is stronger than a penetrating keratoplasty, but these can still give way. This was a patient who had a big bubble DALK, and a year later, she developed a blunt trauma, ended up with dehiscence of the graft junction, loss of the crystalline lens and vitreous, and she underwent a primary repair. And so the endothelium was healthy, so the graft was maintained clear. And another year later, we went ahead and did a secondary IOL fixation using the flange technique, and we were able to give a good visual acuity. So basically, in conclusion, DALK should be considered as the procedure of choice for corneal diseases with healthy endothelium. Surgical techniques continue to evolve, ensuring greater success of big bubble DALK. The pre-op evaluation is very important, and surgical planning is essential to minimize complications. So your big bubble DALK cannot be performed in each and every case. So that's why you need to decide as to which cases you're going to do a manual near Dehiscence dissection and which cases you're going to inject air. And the femtosecond laser technology, the intra anterior segment OCT, these can further improve our outcomes in future. And post-operative management, post-DALK, which I have not included here, is after suture removal. Once the refraction is stable, we do refractive corrections, either in the form of doing topography-guided surface ablation. If the astigmatism is very high, we have done femtosecond laser-assisted astigmatic keratotomy. And in certain eyes where there is a lot of myopia and the anterior chamber depth is adequate with a good cell count, we have done phakic IOLs as well. Thank you for a patient hearing. So I hope this presentation was useful.
Amazing presentation. We are very grateful, and please be patient because there are so many corneal experts here from different fields, like Dr. Thomas Ferner. He's a very nice person. He's a corneal expert. There's a lot of corneal surgeons. There are so many interesting questions. For example, what kind of surgical procedure usually do you recommend with a patient with corneal opacity after a conjunctivitis, for example, for adenovirus? Usually you perform...
If you have adenovirus and you have opacity, those opacities are usually fairly superficial. So you can make an anterior segment OCT and you can see the depth of the opacity and plan. If the opacity is in the anterior 120 microns, I think excimer phototherapeutic keratectomy can be performed along with application of topical mitomycin C to manage those opacities. If the opacity is deeper than that and it's there in the anterior 200 microns, I think you can do a superficial anterior lamellar keratoplasty, either using a two-stage procedure using the microkeratome, or sometimes you can even use the femtosecond laser to do that and still achieve good vision, good outcomes. But if the opacity is deeper than that, then sometimes you can resort to doing a deep anterior lamellar keratoplasty.
Okay, great. Dr. Nicolás Fernández Mejide from Hospital Italiano, Buenos Aires, would you like to ask something?
Good morning. Hello,
Good morning.
Pablo. Dr. Fogla, an excellent presentation as usual. And thank you very much for all your videos and explanations. I have two questions. The first one is, what is your standard diameter for keratoconus? I mean host. And have you seen late onset high astigmatism or ectasia or not?
Usually, ideally, we would like to use diameters of 8.5 or 8.75 because the keratoconus, kind of the ideal thickness is beyond that zone. If you use smaller grafts of 7.5 or 8, you may not be excising the entire pathologic tissue. And often the cone is not central. If it is slightly eccentric, and if you use a smaller trephination, you find that you end up making your trephination a little eccentric. So now we want to make our size more 8.5 or 8.75. The other reason why people don't want to choose a larger size is the bubble does not expand to 8.5 or 8.75. So what happens is when they inject air and they find the bubble is small, then you have the residual stromal tissue in the periphery. So sometimes people like to use trephination size of about 8 millimeter. But to minimize astigmatism, I think if you use a slightly larger diameter, you'll be able to do much better. And even in the best of hands, because the keratoconus, the corneal biomechanics is different across the cornea, as long as the sutures are in place, you find that the visual outcome is very good. But once you remove all the sutures in certain eyes, there will be unpredictable astigmatism, which then needs a secondary procedure to manage that. Sometimes we go up, open up the graft junction and resuture to try and manage this high astigmatism.
Thank you.
Okay, great. I don't know if somebody wants to ask him our resident, please.
Pablo,
I would be happy. I would be happy to hear the experience of the rest of the people as well, because I'm pretty sure that they may have some more points to add, which can enrich me also in doing my surgery better than what I'm doing now.
Great, you're very, very modest. We deeply appreciate your attitude. Thanks, Alex.
No, surgeons in South America are very, very innovative. And I am really impressed sometimes by the techniques that they use. And I find it very useful. And I have a lot of points that I have incorporated in my surgical technique, which have made me improve my visual outcomes of my surgical procedures.
You are a giant of the world of ophthalmology. Please, Federico, ask him.
I want to talk about the macular dystrophy. As we know, macular dystrophy has goutte. Do you think that there is still a good option to do the DALK, leaving what you tell us about the descent that is an abnormal descent and also has goutte? And if you do that, maybe in the future you're going to have to do a DMEC or even another endothelial procedure. Do you still do that? I think that the answer is yes, because you showed to us. For us, it's a yes too. But please, can you explain a little bit more about that? Why?
No, DALK is not a good choice for macular dystrophy. I think my patients with penetrating keratoplasty and macular dystrophy have much better quality of vision compared to DALK cases. The only advantage of DALK is that you have to use steroids less, and maybe the risk of endothelial rejection can be minimized. So if I have a younger patient who's less than 45 to 50 years and has macular dystrophy, for which I need to do a corneal surgery, I explain to my patient that you have the option of undergoing a DALK. And I also explain that there is a possibility intraoperatively that I may convert to a penetrating keratoplasty if I encounter complication. And the second is that after the DALK, because of these residual deposits in the posterior layer, if you are not happy with the visual outcome, you may need to undergo a second surgery to correct that. And I don't think an endothelial keratoplasty will work in that scenario because you have the deposits in the predecimates layer. So even if you solve the problem of removing the Dehiscence membrane with a Goutte and put in a DMAC or a ultra-thin DSEC graft, that pre-Dehiscence layer with the deposits will still affect the patient's quality of vision. So normally, if I see a patient with advanced macular dystrophy, I recommend that you can do a penetrating keratoplasty. I was very enthusiastic early on when I tried to do DALK for all my cases. And after the years, I have learned that now, if I see a macular dystrophy, maybe doing a good penetrating keratoplasty you can achieve much better visual outcomes. And there are a lot of papers that have been published showing suboptimal outcomes, either because of primary graft failure after DALK in macular dystrophy. That's because the patient had poor endothelium. And I've also had cases of macular dystrophy where I've had spontaneous detachment of the decimates without having perforation because the endothelium is not very healthy. And in these cases, even if you go and rebubble, as long as the air bubble is there, the cornea looks clear. But when the air bubble goes away, the decimates refuses to attach, and it again, detaches. So not a great scenario. So maybe that's why for people starting out with DALK, if you see a macular dystrophy, don't attempt DALK in the early part. Maybe do a penetrating keratoplasty. Once you have gained experience and your patient understands and willing to take the risks for the suboptimal outcome in a second surgery, maybe you can try doing a DALK and you can still have a reasonably good outcome in those cases.
Okay, thank you very much. I have another 2 questions.
Yes,
you always start. This is a big discussion, maybe in all the classes when we do DALK. What about the paracentesis? As you show, it's not your, you don't do at the very beginning. You do it after the injection of air. That's correct?
Yes. And the reason behind is that if you make a paracentesis, you reduce the counter pressure from the aqueous, right? Then when you inject air, you have less counter pressure. So what happens is, if you're using a 5 cc syringe and you are using significant pressure to initiate the bubble, the time taken for the eye to visualize the bubble and the signal to go to the brain and the hand to stop pressing on the plunger, and you already have compressed air within the syringe, the bubble can expand very fast. So you will find that if you make a paracentesis, you will see in your surgical cases that you do get a bubble, but the bubble kind of goes like that. So there is no control over the expansion of the bubble, okay? So if you inject more air, the bubble can maybe expand to its maximum limit and it can rupture. The second point is, before you inject the air, you don't know whether you're going to get a type 1 or a type 2 bubble. And we know that the type 2 bubble is a separation between the decimates and the pre-decimates layer. And if you make a paracentesis and you already create a break in the decimates and you get a type 2 bubble that starts, and this bubble, if it reaches the point of the paracentesis and there is already a break in the decimates, chances are that break can enlarge and you can have a rip in the decimates. So for me, not doing a paracentesis, it acts like a shock absorber. That means when I'm injecting air, it allows me time. It's like a safety margin. So I can see my bubble forming, and then it doesn't expand beyond a certain point because the counter pressure is minimizing that. And if I know that I got a type 1 bubble, then I make a paracentesis to soften the eye. And because the plane is already created, you don't have to worry. You can actually stop, bring out your cannula, and you can go back in and inject air, because now you already have a plane with weak resistance. So the air will only go into that space and you can gently enlarge the bubble to the desired diameter. So with using this technique, we have been able to make the bubble go up to 8.59 millimeter, but it does not happen in each and every eye. In certain eyes, even using the paracentesis and softening the eye, the bubble will reach up to 8.25, and then you find that you start feeling that resistance again, like what you had when you had not done the paracentesis. So maybe that's an indicator that at that point you should stop.
Right, thank you for both explanations. And the last one is, do you try to enlarge the trephination when you have the big bubble done? That's what Malbran used to do. He started with an 8.0 and then finishes enlarging manually up to a size of 8.5 or 9. Do you find it difficult?
you can do this. There is a technique that's described by Massimo Busin, where he uses a 9mm or 9.5mm trephine going up to 300 microns. And then he does a lamellar dissection for the 300 microns, and then makes a big bubble only in the center, 6mm. And he opens the bubble in the 6mm area. And then the donor is prepared using a microkeratome, like a DSEC lenticule, which he prepares 9mm, which is 400 microns in thickness, and he places it on top, and then he sutures it, and he has shown very good outcomes. And because it's a large graft, the astigmatism is less. So for indications like pellucid marginal degeneration, I have used trephines of 10, 10.5, where I use the mark with a 10.5, and then I use a diamond knife to make a groove of about 300 microns. And then I do a manual lamellar dissection, but I expose the big bubble only in the central 7mm. And the peripheral stroma, I trim it down and put a large graft, and you can get a good outcome. So if you want to do that, it's good. The only problem is that if you're a beginning surgeon and you make a 9mm trephination and you end up perforating and you want to convert to a penetrating keratoplasty, you are making that to a high-risk graft, and the patient can then have a high risk of rejection. So I think for an experienced surgeon, as you gain more and more experience, maybe you can start working with larger grafts to achieve much better refractive outcomes.
Great. And another question for our residents and corneal fellowships for beginners. When you decide to switch to during the surgical procedure, of course, you are doing a big bubble and you have a Dehiscence broken membrane. When you decide to switch to PK? Thanks.
Well, I showed you a macro rupture. So these days, I kind of, in any perforation, you can manage, I feel. And you can use air or gas to tamponade. So I don't think you should be in a hurry to, so the only thing is, if you have a perforation, you have to complete the surgery first. You don't leave behind a very irregular bed. If you leave behind an irregular bed and try to do a lamellar keratoplasty, your outcome is going to be suboptimal. So you can, try and place sutures. If you have a sharp perforation, you can just suture the stroma without going full thickness. You can place a small stromal tissue over the perforation using some fibrin glue, and then use air to tamponade that break and still continue with the dissection. So using a combination of that, you can do it. But if you feel that the perforation is too large and it is impossible, entry chamber need to convert, so don't prepare your graft surgery. So if you try and strip the Dehiscence before surgery, keep your graft ready, and you have a perforation, you cannot obviously convert to a penetrating keratoplasty. So depending on your surgical experience, if you feel that this is not working and you will be unlikely to leave behind a smooth interface, then I think you should convert and do a good penetrating keratoplasty for your patient. That's why in the initial cases of DALK, I like to do my cases under a general anesthesia, because then you are not pressed for time. If you do it under local anesthesia and you have a complication, then you have to speed up. And that is the reason when sometimes people want to quickly convert and finish the case, because if the block is wearing off and you have to do a penetrating keratoplasty, it can be difficult. So people don't spend time trying to rescue from the perforations and still manage with the DALK.
Great. And Dr. Thomas Ferner, as he does another question about confocal microscopy, has been used prior any decision, because after DALK surgery, sometimes it's not easy to do it.
Yeah, we don't have a confocal microscope in the place where I work. The confocal microscope can be useful to actually look at the cell count, because doing a specular microscopy, the clinical specular microscopy in a lot of these eyes is very difficult because of the abnormal corneal curvature, and sometimes because of the corneal opacities that you have in dystrophies, you cannot image. So we usually use the corneal pachymetry as an indirect evidence that your corneal endothelium is functioning well. But if you have access to a confocal, you can definitely look at the health of the endothelium, especially in scars related to herpetic infections, because in the herpetic scars, sometimes the scars can be quite deep, so you don't know underlying what is the condition of the endothelium, whether it is favorable for a DALK or you need to do a penetrating keratoplasty.
Thank you so much. And one of the last question, Dr. Maria Julia Zunino, please.
Yes, good morning. Excellent presentation. I want to ask you, when you use it in infectious disease, what method of diagnosis? It was about confocal microscopy or OCT, which is the best method to plan the thickness of the deep and the depth of the DALK. And if you use it in infectious disease, which is your experience?
The only infection where I have successfully, where I've used DALK is in acanthamoeba keratitis, not responding to medical therapy. And there you can use a clinical judgment looking at the slit lamp at a slit view. I have the OptoView anterior segment OCT. So we do try and do an anterior segment OCT. But if the infection scar is too dense, you get shadowing, so you really cannot see behind. So then intraoperatively, sometimes you have to do an initial lamellar dissection and then visually inspect the bed and see whether you have achieved a clean bed or not. And even if you do a DALK, we have to continue with the medical therapy even after DALK, because if you did not do that, the chances of recurrence can be high. There have been several papers from China looking at the role of DALK in fungal keratitis, but they have used them for superficial infections, and fairly early. They have waited only a week or two of medical therapy, and then they have gone ahead and done a lamellar keratoplasty. In our scenario, we still continue with medical therapy because we know that the filamentous fungi can penetrate quite deep. They can even penetrate through an intact Dehiscence membrane. So a lamellar keratoplasty may have a very high incidence of recurrence. So I think in acanthamoeba, where medical therapy is not very effective, maybe a DALK procedure definitely has a role to play.
Thank you.
Thank you.
Very
Thank
clear.
you so much. And Professor Sass, please.
Yes, congratulations again, Rakesh, for a great presentation. I'm checking out from when we have to share some vitreoretinal patient with corneal patients, maybe in a phakic patient, and we have to put silicone oil, for example, in PDR patient or trauma patients. How do you deal between silicone oil and endothelium discompensation, and maybe have to make a PK, or what your best approach when you have to deal with a patient? Do you have to deal with a patient with a phakic silicone oil secondary to a trauma or PBR in your practice?
If the overlying stroma is still clear and the patient has silicone oil associated corneal decompensation, you would do, obviously, first you will do a silicone oil removal, and then you can always take the patient up for an endothelial keratoplasty. But if there is a penetrating scar in the cornea, which is giving rise to irregular astigmatism, then doing an endothelial keratoplasty alone may not be ideal. So in that scenario, you will resort to doing a penetrating keratoplasty, but after the silicone oil removal, because with the silicone oil present inside the eye, if you do a penetrating keratoplasty, the long-term survival of the graft may not be too good, because if you still get those silicone oil bubbles coming into the anterior chamber, they will be detrimental to the health of the endothelium.
Great. And in your experience, the viscosity of a silicone oil, it depends if it's 1,000, 100, 1,050 or 5,000 dense silicone oil. Do you see a real difference between the discompensation?
The emulsification is much less with the 5,000.
Yeah.
So I think that is ideal. If you have a patient with corneal problem and you have to use silicone oil, maybe to use with a higher density silicone oil.
That's the point that I want you to offer. We have to put heavy silicone oil in when you have silicone oil and corneal discompensation in affected patients. Yeah, that's what, because here in Argentina or Latin America, we try not to use heavy silicone oil because it's difficult to put, it's difficult to extract. So we try to use maybe 1,000 or 1,200 centistokes silicone oil in maybe in 85% of our cases. Thank you for
It's important to make a good inferior PI in those cases as well, which can prevent the silicone oil from coming into the anterior chamber.
Thank you so much.
Thank you.
Dr. Juan Ribeiro is asking, during the OR, in an intraoperative situation.
Yes,
what
high
you
risk
see-
of endothelial cell loss.
Yeah.
I read the question, yes.
Vamos a ver.
And
Tapamos el ojo
Nicholas has
derecho.
also commented that he does not have any problems
Nicholas.
of doing a paracentesis. That's true. There are a lot of surgeons who have good control over the air injection that they do. So for them, if they make a paracentesis and if they are able to place the cannula at the appropriate depth, they can avoid having the complication. They can avoid, yeah. So if you are able to place your cannula at the right depth and you don't have, so you can avoid having complications by doing a prior paracentesis. But for surgeons starting out, I think it's important when they are in the learning curve, maybe not to do a paracentesis because you're still trying to figure out how much of pressure you have to apply to initiate the bubble. In terms of intraoperative situations, yes, you do. If you have complications intraoperatively, like perforations, and you have to use long-term gas tamponade using 20% SF6 gas, then the cell loss is likely to be a little higher. One of the situations that I have found people have presented and they have shown that the cell loss is a little high is when they don't debulk the cornea prior to the air injection. And the reason is, the explanation which I feel is that you make your trephination, you inject air, you create a big bubble. Then the pressure in the eye becomes very high. So you make a paracentesis to release aqueous to make the pressure normal. Now, when you get a big bubble, your posterior layer is pushed backward. Yeah, that you can see from the configuration of the big bubble. So when you release the aqueous, after releasing the aqueous, your entire endothelium is pressed on the lens iris diaphragm. And you have a soft eye. And at that moment, if you try to do a debulk, you are holding the stroma and you are doing lamellar dissection to remove the anterior stroma because of bubble through is sometimes a little bit more difficult than to do it after you have done a debulking. So you spend time doing the debulking. So that time that you have spent doing the debulking, your endothelium is in contact with the lens iris diaphragm. So the central area where it is touching the lens iris diaphragm, you can have cell loss from some amount of lateral movement. So I have surgeons who have presented cases to me saying that they have done a successful big bubble DALK without any perforation, but in the early post-op, they have found very minimal central corneal haze or a central corneal edema that takes maybe a week or two to clear up. So this is something which I have an explanation, which I feel is relevant to the technique. So if you can avoid excessive manipulation, you can reduce the endothelial cell loss.
Again, we are very, 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 very grateful, and we are very, very, very proud to be our visiting professor at Maimonides University and Buenos Aires University. Thanks again. And well, I hope I'll see you very, very soon. Thank you very much. Greetings from Buenos Aires.
Thank you. Thank you. Thank you. Thank you, everyone. Bye-bye.
Ya, entonces hablamos. Thank you, Rakesh.
Thank you. Bye-bye.
Gracias a todos. Los docentes de la cátedra, quédense un segundito.